development. And we are just thrilled to be able to offer this webinar, Harm Reduction 101. Again, we've offered it a couple times in the past, but we are happy to have Dr. Laura Poblumby here to help guide us and help us learn around harm reduction for the next hour or so. So if you could, in the chat, and I think some of you are already doing that, so thank you. Just say where you're from and kind of so we know who's in the room, the virtual room, and how you would describe harm reduction. That would be great. So we'll kind of just look. Thank you, Ashley from Otter Tail. Harm reduction is compassionate care for vulnerable people from Duluth. Oh, that's Jennifer. Welcome, Jennifer. Nice. Jennifer is one of our colleagues in Extension. Annie, thank you from Marshall, Minnesota. Sue, again from Otter Tail. So thank you. So if you get a chance, and you can do it as we kind of get started. Sarah, thanks for joining Pine County. I'm going to turn it over. Well, first we're going to do, can you forward one slide? Forward slide, Laura. We're just going to ask you as well one other question while you're thinking about putting stuff in the chat, but while you're participating in this webinar today, we like to gauge that as for future information for our webinars for our next series. So whether you're for personal use, professional use, or both that you're attending this for, we'll give you a little time. Welcome, Diana. Greta, welcome. Elizabeth. So it looks like so far we'll give let's see, we'll give one, maybe a few more seconds here. And if everyone could just mute, that would be great, just so that everyone can hear and be able to participate in the webinar. Thank you. Okay. So it looks like, according to the poll, that that half of you are here for professional reasons. 6 of you are here for both personal and professional reasons, and 1 person for personal reasons. So thank you for sharing that. I'm going to share the reasons. Let's see. I think you can all see those results. So thank you for filling that out. That's very helpful for us future webinars, and then just for Laura in presenting as well. So, okay. And if throughout the presentation, if you have any questions or any comments, if you put them in the chat, that would be great. I'll be monitoring the chat, and Laura stops periodically to answer some of those questions. So if you need anything, just put it in the chat, and then I will be monitoring that. A huge kudos to Rick Meyer for helping us support this webinar and making sure that we have everything good to go. We could not do this without you, Rick. So thank you so much for your help. So, okay, I'm going to turn it over to Laura.
Thank you. So thanks everyone for joining today. We really appreciate you making time for this and recognizing this as a priority. We're going to quickly review today's objectives. I will be pausing periodically, as Mary Jo mentioned, because I don't want to move too fast and then have anyone forget their questions if you're anything like me. So I'll give you a chance to ask questions as we kind of get to them. So we're going to talk about the past and current trends in substance use and how they inform community-based harm reduction practices. We're going to talk about health and social benefits of harm reduction programming. We'll also look at some myths surrounding harm reduction and how we address those myths, as well as the benefits of and evidence behind different harm reduction approaches, including naloxone, syringe access, and fentanyl test strips. And then also strategies that reduce stigma and engage patients or community members in care related to substance use disorders. So before I begin, I usually like to just acknowledge all the people that have helped inform this presentation. So a lot of community partners work in the area of harm reduction. I also like to do a land acknowledgement when I do presentations. It's a new practice for me, just recognizing that the land that I live and work and play on is traditional lands of the Ojibwe people, and appreciating the land as it is theirs. So just wanted to say that, and really we're going to start then with our presentation. So I want you to look at these pictures that I have here and let me know what do you think these have in common. And you can just stick it in the chat. Put in the chat, what do all these things have in common? We're starting with the easier questions here, so. And when I'm presenting, I can't really see the
Yep,
chat.
So
Okay,
I was
thank you.
just, yeah. So safety, prevention, safety tools,
Yes.
right?
Okay.
Yes.
Yes. Perfect. So these are some of the tools we have that are prevention, right? Like these are all the things that we hope we're never going to need them, but if we do, they're there for us, right? Like we don't wear a helmet expecting we're going to get hit by a car every time we ride the bike, right? I hope not. We don't wear a seatbelt thinking that that for sure I'm going to get in a car accident today, so I'm going to wear my seatbelt. No, we just, and we have a fire extinguisher in our house, and we have vaccines. We have these things because the evidence shows us that they work. And even though we might never see them work, we might never, hopefully, ever need to use that fire extinguisher or ever have our lives saved by a seatbelt or helmet or vaccine. We just don't know sometimes with vaccines, right? But these are all tools we have that we pretty much recognize the value of them as a society, and as they're part of our life because of that. So just want to kind of share that because that's kind of the approach we're going to talk about with harm reduction. It's similar. An approach that's backed by evidence that we should just accept, right? Because there's evidence that proves that they're valuable. But unfortunately, there's some barriers such as stigma, which we're going to also talk about today, that keep us from recognizing the value of harm reduction, at least some of us. So what about these pictures here? So these pictures kind of represent some of the harm reduction practices we're going to talk about today. So we have a tool called naloxone or Narcan that is a readily available drug. It's available over the counter through a protocol program at most pharmacies, where pretty much anybody should be able to walk in the pharmacy and pick up naloxone and have it with them. Or they can obtain it from a harm reduction agency. So it's readily available, can save people's lives so easily, really in like a matter of seconds. And yet, why are we not all carrying it? And why is it not in all of our first aid kits? It's because of stigma. And so the same thing with fentanyl test strips. This is another tool we have. Of course, with new fentanyl analogs, these aren't quite as accurate as they used to be because some of these analogs are escaping their use, but there's still a really valuable harm reduction tool that we have. And we know that even the act of people testing their drugs for fentanyl really makes them more likely to engage in treatment, just that act. So, and then we also have needle exchange programs and the ability to purchase new syringes. And again, that is evidence-based. We have publications, we have public health practice that tells us that saves people's lives. It saves us money. It should be a no-brainer, honestly. And yet we have such a problem with it in our society because of stigma. So what is harm reduction? Very simply, it's doing things that make it safer for people to participate in activities that could lead to harm, but really are unrealistic to ban or eliminate. So an example is on the right there is condoms, right? Like they can reduce the risk of all sorts of things. Pregnancy, unplanned pregnancy is one of them, but a lot of sexually transmitted infections as well. So you can see how the advertising for condoms has changed really. So take a look at that. I didn't have one because I didn't use one because I didn't have one with me. So again, if you don't have a parachute, don't jump. So just how they change the language around condoms, and maybe that's a model for us. So again, can we realistically eliminate contacting other people? So not really. That's why we have vaccines, right? We had some experience in all of us being socially isolated. And it didn't go very well, right? So we have vaccines so that we can all be around each other and not worry so much about getting each other sick. We have sunscreen because we like to go out in the sun, but we recognize that there's risks with that. And so, sunscreen, that's another harm reduction technique that really takes what we have for science and allows us to enjoy the things we want to do and reduce our risks of bad outcomes. We have seatbelts to make driving safer, and then we have condoms to make sex safer. Again, we're just trying to frame this, right? And I think that's one of the challenges. How do we talk about this, like with other colleagues, people that are not bought in? So again, here's our objectives today. But again, we're going to talk about stigma primarily. So here's a figure that is really sad and depressing, and probably something that all of you have seen some version of. And this is a chart with drug-involved deaths basically by ages and gender. And so you can see how those numbers have continued to go up since 1999. So on the left, we have 1999. On the right, we have 2020. And those purple bars represent the number of people that have died each year. And when we look at graphs like this, we have to remember like 91,000, almost 92,000 people, 92,000 people. Those are all people of value. Those are people that are doing great things in the world, people that didn't mean to die, people that are somebody's loved one, they're a mother or father, or son or daughter, aunt or uncle. Like they're not just numbers. So we really, when we look at graphs like this, have to be so careful and recognize these are people. And most likely some of you attending this presentation right now, this webinar, have been very personally impacted by the opioid crisis. And our hearts are with you. That's why we do this work. And we just want to acknowledge that this could be a tough presentation to listen to and potentially triggering. So, but we do want you to know that our hearts are with you. So thank you for being here, all of you, and recognizing that all of these lives are valuable and we need to do better. So we know over 70% of the nearly 71,000 deaths in 2019 involved an opioid, and that was a little older data. I know the number is just the same as in 2020, probably a larger percentage. So then we're really going to talk quickly about the different waves of the opioid crisis. So I think that this is tricky because I think there's a lot of people that know that opioids take a lot of people's lives and they're just not aware of how that's changed. So some people are still under the impression that prescription opioids is what's killing everyone, and that's just not the case. So we're going to look at this graph here. So you can see the first wave is where we did have a lot of prescriptions out there for opioids. We didn't realize how likely people were to be become dependent on opioids. Our prescribing practices were a little more loose. We didn't know what we know now, and so a lot of people became dependent on opioids that were prescribed to them. And a lot of prescribers weren't paying attention when people's doses increased. So we ended up with an epidemic and we didn't see it coming. Maybe some people did, a lot of people didn't. So we started to see a rise in prescription opioid overdose deaths that started in 1999. So that was the first wave, and the first wave is prescription. Then we realized we had a problem. We saw, oh my goodness, like here we are as healthcare providers trying not to do harm, and yet we're doing harm by dispensing these drugs and prescribing these drugs. So let's cut back on that. Maybe that will help. Well, it turns out that didn't help because a lot of these folks were already dependent on opioids because of our bad prescribing and our bad dispensing. And so when we took away their opioids because of stricter prescribing practices or cutting them off, their bodies were already dependent. You can't just stop taking an opioid without very serious consequences. And so as a result, we saw a rise in heroin overdose deaths in 2010. And those were a lot of people that were on opioids that had their opioid cut off, and they ended up turning to heroin because heroin is also an opioid, and it was readily available on the street, a lot cheaper. And so we ended up seeing a lot of people that turned to heroin that were prescription opioid users. And as a result, we saw an increase in deaths. The third wave, which started in 2013 and has really become a lot more intense in the last couple years, is a rise in deaths because of synthetic opioids. So can somebody put in the chat when we say synthetic opioids, what are we talking about? One drug in particular. That we're hearing a lot about lately. Anyone?
There's nothing in the chat yet.
Oh, okay. Starts with that F, fentanyl. Okay, so fentanyl. Fentanyl is a synthetic opioid. Fentanyl is actually a prescription opioid too. So people are on fentanyl patches. It's kind of a high dose transdermal way of getting an opioid. But that's not what we're talking about. We're talking about synthetic fentanyl made in a lab. And unfortunately, I've been told it's not very difficult to make fentanyl in a lab. And it's very, very potent. And so a very, very tiny amount of fentanyl is deadly compared to a larger amount of other opioids. And so our third wave in the opioid crisis was because of synthetics such as fentanyl. And most recently, what we're seeing in the last 6 months to a year, more and more we're seeing So they're called fake pills, basically. So they're pills that look like a pharmaceutical. They look exactly like hydromorphone or oxycodone or even Ambien or benzodiazepine. So what drug dealers are doing is they're buying pill presses online. They're readily available. They can just put some powder in the pill press along with fentanyl, and they just press it and make it look like a pharmaceutical. And so they're marketing it especially to youth, and they're using social media such as Snapchat. And so within the last 6 months, the DEA has put out an advisory, a warning that especially youth are at risk because of these fake pills. So people are buying these pills thinking that they're getting an opioid. They're thinking that they're getting a benzodiazepine or a sleeping pill, things that are maybe harder to get, or they'd have to go into their doctor's office to get them. And so they're self-treating, buying pills that they think are going to help them, but really they're just fentanyl. And so that has been, maybe that would be wave 4, honestly. We haven't put that data together yet, but we did know the numbers went up significantly in 2020 and 2021. So that is the most recent trend, that it's really important if there's youth in your life or people that you know are maybe not seeing the doctor's office, but still have pain and they're trying to self-treat. That's really important for people to know that that's happening. So we're going to look at our history to kind of, again, frame what we're talking about today. So we've had an interesting relationship with drugs in the United States, starting with the war on drugs in 1971. While it was aggressive and expensive and it really tried hard to curb drug use, it really did not do a lot. It did not help our situation. So you can see, here's a graph, the percent of high school seniors reporting illicit drug use in the past month. You can see that number has not dropped sharply, right? So teens are the most common age group to use drugs, have shown little net reduction in drug use since 1975. And remember, that's when our war on drugs started. And that's per the Monitoring the Future survey. So those attempts to scare youth, maybe it worked for some youth. I think it worked for me, honestly. I'm a more cautious type, so I remember seeing things when I was in DARE, and definitely scared me. But by and large, the data does not indicate that a lot of those are effective, unfortunately. And I also want to show you this other graph here. So this is the median bulk price of heroin per pure gram, and you can see how that's gone down in price. Well, that kind of explains that wave, the second wave that we talked about, and that, we cut off people's opioids and heroin was pretty cheap. So that was what they did. That was their substitute. And now fentanyl too. Fentanyl is in almost all of our drug supply. So that's one of the reasons it's so deadly, is that we have people who don't even know that they're getting fentanyl. Remember, they're buying what they think is Ambien off the street, or they're buying methamphetamine. They've never been an opioid user. We have people that access harm reduction and they're like, oh no, I'd never use opioids. I only do meth. And then they found out that there was potentially fentanyl in their meth, and like, well, I'm not going to use meth anymore because of that. So it's interesting because people are kind of loyal to their drug. But long story short, people that are cocaine users and meth users, those are not opioids. But when they're laced with fentanyl, they become deadly, and those people can experience an opioid overdose. So again, we're seeing here on this chart the bulk price of heroin going down. And per the Office of National Drug Policy, these prices have been falling dramatically. And you can kind of see how those prices have fell. So this effect then, where crackdowns on drug production in one area are basically shifting to another. So it's called the balloon effect. And it really is one of the reasons why our war on drugs didn't work. The market just shifted. So that's a little bit of background. Now we're going to talk a little bit about substance use. Again, we're kind of talking about some of these things that's important background information for us, and really buying into harm reduction and why this is a good strategy. So a lot of times people think, so I'll do a quick intro here. So I'm trained as a pharmacist. I'm not a psychiatric pharmacist, unfortunately. I wish I were, but I do have some experience working with people in recovery and people that are still were still using drugs when I was a treatment court team member. And so that really, I think, helped me to learn more about the recovery process and to really gain respect for all the work that goes into recovery. So there is this myth that people that relapse when they have a substance use disorder are somehow like less worthy, which is really frustrating to me as a healthcare provider. So So here's a stat. So the relapse rates for substance use disorder is right on par with other chronic diseases such as hypertension and asthma at 40 to 60%. So what happens though in healthcare is we have pharmacists and doctors, especially pharmacists. So I'm a pharmacist. I feel like I can call out pharmacists and say we're doing a bad job. So we have pharmacists that don't want to dispense naloxone because they feel like they're enabling, or they don't want to sell new syringes because they feel like they're enabling. And that really makes me sad. So it'd be the equivalent of somebody with asthma coming into the pharmacy and looking for their rescue inhaler, right? So asthma is the same thing. There's controller inhalers, controller meds, and then there's rescue inhalers. So if somebody came in looking for a rescue inhaler, their albuterol, would we be so judgy of them and say, "Oh my gosh, look at you! Like I thought you'd recovered from your asthma, but here you are again, looking for another inhaler. Like what's wrong with you?" And like, treating them like it's a moral failure. Well, we do that with people with substance use disorders. We think that by giving them naloxone, we're just enabling them. Oh, now they're just going to go out and use it, and they're going to relapse. And we're so judgmental. But if we really flip the narrative and looked at that in comparison to any other disease state, we'd realize it's right on par. So we really need to shift our thinking. And I'm talking about healthcare professionals specifically. When it comes to treating substance use as a moral failure, it is not. And I think one of the things we're doing then is trying to provide some education. We do this with our MAT 101 webinar, which I think we might have online. I'm sure Mary Jo can put a link in the chat. But really talking about the neurobiology of addiction and how addiction changes the brain, it hijacks the brain. And our healthcare providers don't necessarily understand that. So really, at these rates, addressing substance use relapse should be an expected part of your work. We have people in the recovery community that just tell us, relapse is just considered a part of recovery. So again, it's important to learn from the people that are professionals in that area. So really, this all ties into stigma and shame. We need to be honest about rates of recurrence and help others feel safe in asking for help. And this is so important. The statistics tell us that about 80% of people with a substance use disorder will never access treatment for their disorder. Can you imagine if that was the case with asthma? If 80% of people with asthma never got care, or 80% of people with heart failure, it's hard to even imagine that happening. And yet that happens with substance use disorder because of the stigma. So that's something we all need to think about. We're going to talk about what we can do to help change that. So unfortunately, eliminating drug use altogether seems more and more like an unrealistic goal. So considering this, harm reduction offers tools to reduce the harms that stem from drug use. So where are we today? We're going to look at these myths. So the first myth, that harm reduction promotes harm to the community. And this is one I feel like is more common within our healthcare provider circles. So in reality, harm reduction programs are shown to be cost effective, and they slow rates of HIV transmission in a community as well, and hepatitis C for sure, and other hepatitis forms as well. Harm reduction is a great community investment for many reasons. It saves lives, it saves costs, and even better, harm reduction programs are shown to facilitate connections to social programs and support for people who use drugs, making them more likely to enter treatment for drugs. So that is amazing, that we are providing a service that not only saves their lives, most likely, but it definitely reduces disease, and it definitely helps to clean up the community. We didn't even talk about that, but syringe exchange services are shown to really help the community. There's less syringes in the community. It's less cleanup for everybody. It saves people's lives, saves us money. And yet people are not tuned in with the data. And so they are using their own preconceived notions of right and wrong that are not well informed to really oppose this. So another myth, harm reduction only enables and increases drug use. This is definitely one that's common within our healthcare providers. So again, they've looked, there's been research, there's no connection between harm reduction and increased drug use. Even better, since harm reduction groups typically offer syringe disposal and hand out medical sharps, their presence correlates with fewer discarded syringes. Like I said, it also reduces the spread of disease. It helps people enter treatment. It has a lot of great benefits. So that is one piece of harm reduction. The next one is naloxone. This is the one I talk about all the time. sometimes multiple times a day. I do a lot of naloxone trainings. Again, we have, Mary Jo can put the link for this too. We have trainings online, one that we just launched, if you want to learn more about naloxone. So what is naloxone? Naloxone is the same thing as Narcan. So this is a drug that's available through the pharmacy or through harm reduction agencies. We should be able to access it in multiple ways. And basically, it's a high affinity mu receptor antagonist. So what does that actually mean? It means that it looks a lot like the opioid in the body, but it reverses its effect. So the way that and we can do this in a lot more detail in a training, but the way that I like to explain it, here's the mu receptor, here's the opioid. Somebody consumes an opioid, whether it be snorted, inhaled, injected, the opioid ends up in the bloodstream no matter what. It binds to the receptor and basically shuts off your body's desire to breathe. How naloxone works is it also ends up in the bloodstream, whether injected or given intranasally, where it gets absorbed in these blood vessels in your nose, comes along, kicks the opioid off the receptor, and then binds in its place. When the naloxone binds on that receptor, it doesn't send that same signal to the brain to stop breathing. So when the naloxone is in the system, the person's desire to breathe comes back. So it's a wonderful drug. It's very, very safe. All it does is work in that one receptor. So we don't have to worry about causing somebody harm. If they look like they might be experiencing an overdose and we give them naloxone, maybe we're wrong. It doesn't matter because we're not going to harm them. So it's really, I'm a pharmacist. I'm trained in drugs. I love this drug. It's one of the very few drugs we have without side effects. If we were wrong and we gave somebody epinephrine, we could really seriously cause them harm. But with naloxone, there's no fear of that. So I highly recommend that you do the training for naloxone. It's really, really a accessible, life-saving drug that we should all have. We should all carry it with us. I have multiple doses in my purse, in my bag, wherever I go. Actually, my son, we were at a track meet last night and he pulled out a naloxone kit and dumped it on the bleachers. And so we really have it everywhere. So really do the training, carry naloxone, have it with you. You could save somebody's life. It's so easy. And again, there's so little potential for harm. So there's different formulations. There's the intranasal branded Narcan nasal spray. So that's one that most people have heard of. That's approved for adults and children of all ages. It's a little more expensive, but that's the one if you went to the pharmacy and asked for it, that's the one that they'd give you. Most likely your insurance would cover part of it too. You can bill it through your insurance. So it would and just end up being whatever your copay is for insurance. There's also the injectable generic, which is the dosage form that our harm reduction agencies do the most dispensing with. And so we can get a lot more doses out in the community with the same amount of money if we use the injectable generic. So that's another formulation. There also was Evzio, the auto-injector. That one actually isn't made anymore. It was so expensive that it wasn't actually being dispensed. It was really neat though. It was kind of like the EpiPen that talks you through how to give it. It was the same sort of thing. Of course, if you're experiencing an opioid overdose, you can't give yourself naloxone. So you'd have to have somebody in your household or near you be able to give it to you. And then we have the injectable generic given intranasally. This is the sort of form that you'd see like on crash carts, but it's also used by some EMS providers. So how do we get naloxone in Minnesota? We have harm reduction agencies across the state. So we have the Rural AIDS Action Network. They're based out of Duluth, but they also have branches across the Iron Range. So that you can access naloxone from them. They also have another location in St. Cloud. We have Harm Reduction Sisters, which is based out of Duluth, and that's a mobile service. So they will come to you and bring you harm reduction supplies. And then we have Steve Rumler Hope Network, which is based out of the Twin Cities, but also has hubs across the state. So we do have a number of harm reduction agencies doing this work. We also have pharmacists, the ability to, like I mentioned, you can go to the pharmacist and get naloxone. And basically, this is the pharmacist prescription per protocol. So there's a pharmacist that's kind of signed on with a provider. So they have to be trained for this, screen for patient understanding of how it works, and provide education. We have a Good Samaritan law in our state too, because we do have a healthy fear of doing harm to people, right? And that's good. We don't want to just inject people with drugs and not have any sort of caution. So in our state, it's called Steve's Law, and that's the opioid specific Good Samaritan law. And this is for a person who gives somebody naloxone. They're seeking medical assistance for somebody who is experiencing an overdose. They are immune from prosecution. So again, this is a person who seeks medical assistance. Maybe they call 911 for another person who is experiencing a drug-related overdose. They can't be charged or prosecuted for possession, sharing, or use of a controlled substance or paraphernalia. We get good questions all the time, and I believe that if somebody has an outstanding warrant, this does not apply to them. So, but people that are currently using drugs and giving somebody naloxone are aware of this, largely from my understanding. We also have some myths, of course. We have myths about all of our harm reduction practices. Some naloxone specific myths are that naloxone is a controlled substance. We know that it's not. Actually, I'm going to hit a quick pause. I said I was going to pause more often, and I haven't done a pause. So before I get into the myths, what questions do we have?
So I don't see any right now. Let me just scroll up. But if there are questions, you can either unmute real quick and ask, or you can pop them in the chat too.
Okay, I'll give you a second here just in case.
And I did share all of the resources while you were talking on our website. So I know that everyone just got inundated with all of those. So, and we can send those out in an email after as well. So if you can't grab them from the chat.
Mm-hmm.
Okay. I don't see any, so I'll keep monitoring. Okay. But please ask questions.
Yes. Okay, so now we're going to talk about the myths around naloxone. So the first myth is that naloxone is a controlled substance. That one I totally understand. So naloxone works the same way as an opioid. So I think people just assume that it also is an opioid, and it's not. It's a opioid antagonist, and that is, because it's not a controlled substance, that's why it is so readily accessible in the community, why we can have community groups giving it out, why we have a collaborative practice agreements and protocols in place so pharmacists can dispense it. We also have the myth that there's automatically going to be aggressive behavior after administration. We've probably heard stories about people waking up and being aggressive. One thing I didn't mention, a lot of times when people are using opioids, they're combining it with a stimulant. So some of you have probably heard of speedball. So that's when you combine an upper and a downer. So an upper would be like methamphetamine or cocaine. Those are stimulants. And then a downer would be like heroin or fentanyl. Or opioids. So opioids are downers, stimulants are uppers. So if somebody's having an overdose from too much downer and we give them naloxone, we're taking away the effect of the downer. It's gone. What we're seeing now is somebody on meth or somebody on cocaine. So some of the aggressive behavior, or people waking up agitated and just obviously they're going to wake up confused. They don't know what happened to them. But a lot of that is because there are people that have other things in their system, a lot of them being stimulants. There's also that myth of harm related to administration. So I think as we all learn about how naloxone works, that it is a really safe drug. If we give it to somebody and we're wrong, we're not going to hurt them. It's fantastic in that respect. So we don't have to worry about causing them harm. The only potential side effects of naloxone are nasal dryness, if you give somebody the nasal formulation, and then potentially injection site reaction if they're giving injectable. So that would be like the same thing as a flu shot, right? And really, when you look at, a sore arm or sore leg versus nasal dryness compared to death, those are pretty minor. There's also the myth that naloxone enables continued opioid misuse. Again, we know that's not true. People are going to use drugs regardless of whether or not they have naloxone because they're dependent on that drug. They are physically dependent. And so giving them naloxone just gives us an opportunity to save their life if they take too much. And again, we have data that backs harm reduction. There's also the myth of significant liability, which again, as we learn more about how these drugs work, I don't think we need these, honestly. I mean, like nasal dryness and injection site reaction. I mean, I guess if you injected somebody in the wrong place, like maybe in an artery, you could cause them harm if you didn't inject them in the arm or the leg. But that's part of what the training is, injecting into those large muscles. If you inject it in the wrong place, I could see potentially being worried about liability, but really they're safe drugs. So again, people are worried though, and understandably so. We also have syringe access programming that we wanted to talk about. So these are called needle exchange or syringe exchange. This is another evidence-based program where they take in used syringes and dispose of them as medical waste. And before I get started here, I do want to say, so part of what we need to do is change the way we talk about substance use. And one thing I am always trying to, and I catch myself, we don't want to say clean and dirty syringes, because again, when we say clean and dirty, that's again contributing to the stigma around substance use. Or saying a clean and dirty UA or clean and dirty drug screen. So really, if we can call them new or sterile syringes instead of clean, and then used syringes instead of dirty. I know it's a tough one if you're used to using this language, but those are little things we can all do to help change the narrative. So again, what these programs do is they distribute new sterile syringes along with much more. So it could be tools to prepare drugs, HIV and HCV testing, which can save people's lives, handing out naloxone and fentanyl test strips, again, life-saving. They offer connections to treatment and recovery. And a lot of times the people that work in these areas are really skilled. I think a lot of people that work in this area are just genuinely caring of people that have a substance use disorder, and they know how to refer them caring, like in a caring, empathetic manner, and they have success in that. They also offer medical screenings and can help with wound care. So the benefits of syringe access programs, per the Center for Disease Control, and they have some good resources online. They save lives by reducing the risk of overdose. They're associated with a 50% decline in HIV transmission. Here in Minnesota, we have a big problem with HIV and Hep C. We really need to do a better job in getting new syringes, sterile syringes out into the community. So this is something we should all be thinking about and paying attention to. We know that people that use syringe access programs are 3 times more likely to stop injecting drugs. And then law enforcement has a reduced risk of needle stick, no increase in crime, and lives saved. And also, as another benefit, 86% fewer syringes are in the community when compared to cities without a syringe service program. And then additional findings from other studies. So these are non-CDC. That other slide was CDC. So areas with syringe programs are likely to have lower rates of HIV and Hep C. People who inject drugs and use syringe programs are 5 times more likely to enter treatment. And then these programs reduce healthcare costs by preventing HIV and HCV infections as well as overdose. So it's not just the CDC, it's independent research that backs this as well. We also have another tool called fentanyl test strips. This is something that we've started providing with our grants recently, and they've been in very high demand. It's really encouraging to see that people are using these. So these are products that are designed for testing drug supply for fentanyl. They can be repurposed to detect fentanyl and most fentanyl analogs. Now, there's some fentanyl analogs that are escaping detection, so that's important to be aware of. But they are inexpensive, they're sensitive, and they are saving people's lives. So again, benefits, more and more of the street drug supply contains fentanyl. Like I mentioned, it's in cocaine, it's in methamphetamine, in some places it's even in marijuana. So we really don't know what's in the drug that we're getting. This test strips and proper education can help people who inject drugs to avoid life-threatening overdoses. And again, they're potentially less useful in areas where people believe fentanyl is in every street drug. So they already assume there's fentanyl in their supply. They might not see the need for testing. So I'm also going to talk about a new initiative in harm reduction, and that's supervised consumption sites. So again, could be a big jump mentally for some people that, if you're just learning about harm reduction and you weren't even sure about naloxone, and now we're talking about supervised consumption sites. But just hear me out, because again, there's evidence here that this is something that saves lives and again has huge benefits for the community. So these are sites for people who inject drugs to do so safely under the supervision of trained personnel. They reduce the volume of discarded syringes in the community, increase connections between people who inject drugs and healthcare providers. Again, so it's kind of like harm reduction with a place, like a specific place where people can go. Instead of just handing out their harm reduction supplies and sending them on their way, they have a location where they can be safe and monitored. It also saves the healthcare system's money based on HIV prevention. There's over 100 sites in 11 countries, so it's gone very well in other places, but not so much in the US. I know there's one in New York, and there's also one in Rhode Island, I believe. And there's also a group of us in Duluth that are starting some discussions on how would we lay the groundwork for one in Duluth. So it's something that lots of communities are working on, but as you might imagine, there's a lot of barriers due to people's preconceived notions of what these are and what they would mean for the community. Another new initiative is decriminalization. So this is minimizing the social exclusion of people who use drugs and creating a climate where they're less fearful of seeking and accessing treatment. So Portugal is kind of the country that people look to when they talk about this. So they decriminalized illicit drugs in small amounts in 2001, which led to a reduction in the number of recent and current drug users, a reduction in new HIV infections, and a reduction in drug-induced deaths. So um, what is decriminalization though? What are we talking about? It's not the same as legalization. So decriminalization is when you remove criminal penalties for use and possession, versus legalization is when you remove criminal and civil penalties. And then decriminalization is when police give tickets for possession and make arrests if tickets aren't paid, versus legalization would be where it's just legal, like New Jersey regulates and taxes marijuana like alcohol. So those are just some things to think about if we're stretching our minds and really looking at what harm reduction can do for our communities. So at this point, we have some time for questions. So I look forward to whatever questions you have for me. And if you are someone that has expertise in this area, we would love to hear from you and hear your comments as well.
Yes, so if there's no questions in the chat right now, but if, we can just unmute, or you all could just unmute if you have questions. And like Laura said, if anyone works in the field and has some experiences or information they want to share, that would be great too. So, okay, Greta has a question. What vendor would you recommend to purchase the fentanyl testing strips?
Oh, let's see, Mary Jo.
I can search for that, the name of
it's in our inbox, I know.
Yeah, I'll search for that.
Yeah, so Mary Jo and I order fentanyl test strips frequently. This is something to think about depending on your state. So in Minnesota, we can order them and distribute them. I have heard in other states that might not be the case because it might be considered drug paraphernalia. So definitely if you're not in Minnesota, something to think about. So fentanyl test strips, what we do is we purchase the strips. And sometimes people just give out the strips on their own, but what we like to do is we distribute the strip with some sterile water that can be used with the strip. And then we also give them a resource card that has resources. So it has instructions on how to use the strips. And then it also has treatment and harm reduction resources in their area. So that's what we do. We just stick it in a Ziploc and we hand it out. We've done it as a part of care packages as well, and that's gone really well. So yeah, Mary Jo and we order
just put
a lot
in the chat. It's VTNX, and I just put the website, and then here is the number of the person who I connect with usually. But it's pretty simple, and they to order them, and they come in boxes of 100. So keep that in mind.
Mm-hmm. Thanks for the question.
Other questions? Jennifer is asking, do you think that community stigma is an equal issue with healthcare stigma?
Yes, I would say equal but different. So community stigma, I think, is really difficult because so we have people who are like in recovery, right? They are working hard in their recovery. And the community stigma keeps them from getting hired at a job. Even though they are in recovery, they've been doing really well, they can't get a job to support their family. I've been in focus groups with people who have said, I've been in recovery for however long and I can't get a job because of my criminal record or people knowing that I did drugs. I might just have to go back to selling drugs because I have to be able to support my family. So people get discriminated against when they're getting hired. They have a hard time in social circles. So, they went and engaged in recovery and they've been sober, and yet they know that they need a sober social network, right? Because you can't hang around people that are still using drugs if you're trying to maintain your sobriety. It just doesn't work. And yet the community stigma keeps people from being friends with them. So how are they going to be happy and healthy if they can't have friends? And this happens in rural areas in particular. We've heard of people who've been really doing awesome in their job. They got hired, they're working hard, doing great. And then all of a sudden their employer decides to do a criminal background check 6 months after they've been hired. finds out they have a criminal background and they get fired, even though they've been doing a great job. So these are all stories that I hear through the research that I do, and we know they're impacting people. So that's community stigma. Healthcare stigma is when we have healthcare providers who say, I don't want to prescribe medications for opioid use disorder because I don't want to deal with those people. Not really realizing that those people are already their patients that are just struggling silently with a substance use disorder. We have people in pharmacies that are calling somebody an addict and a junkie, and they're refusing to dispense naloxone. They're refusing to sell new syringes. They are refusing to stock medications for opioid use disorder like Suboxone. So I think that they are both significant, and even though they're not equal, they are both really dangerous and really causing a lot of loss of life. I'm going to add one more thing. So usually people attend this presentation, they want to know, what can I do? What can I do moving forward to do my piece? And I would say the one thing we can all do is think about the language that we use when we talk about substance use disorders. So really recognizing them as people first. So not calling them an addict, not calling them a druggie or a junkie, recognizing that they are a person with a substance use disorder, or they are a person with an opioid use disorder. They are a person first, and really eliminating words like clean and dirty when we're talking about substances. Those little things can make a big difference, because you don't know who in your family or friend circle might be struggling. And it could be the language you're using and a stigma that you're perpetuating in your language that makes people not want to approach you. You could be the person that helped them. And maybe you already are. So that's something we can all do, is to just be kind and gentle and aware of our language, so that those 80% of people that don't want to access treatment because of stigma might start thinking about it. And again, when a parent goes into treatment, that impacts their kids too, right? Like, it's not just that one person that benefits from them going to treatment, it's an entire family and an entire community. Other questions?
Hi, I don't know if you can hear me.
Mhm.
Okay. I don't know, maybe it's too much in the weeds, but are there any particular pros and cons with the Portugal goal? And obviously I don't really even know the details of how they kind of implemented their approaches, but I just didn't know if you see, obviously I know there'd be like social, political barriers to actually implementing that, but do you feel like it's a pretty, great model, or you have reservations about certain aspects of it, or?
Oh, that's such a good question. So I've actually been, that's kind of an area of professional development for me, where I'm like, I need to visit Portugal, actually. I've been wanting to visit Portugal and like do like a learning tour for a while pre-COVID. So unfortunately, I don't know a whole lot. I think you'd almost have to like go there and see it. There are a fair number of journal articles that talk about it. I can't, I did some more research on this several years ago, and I haven't looked at it recently, but I do know that they are a model that a lot of countries look to. So I think I think whatever they're doing is working. I can say that other countries look to them and really cite them a lot. So for whatever that's worth. But I have my email here. So if you find anything good and want to share it with me, I would sure be appreciative.
Other questions? Let's see, I'm not seeing any in the chat, but if you would like to unmute, please do.
I guess my follow-up question is there a certain state that you see as a model here in the United States?
So I think, so New York has has the supervised consumption site. They seem to be pretty advanced compared to other areas. So I would say generally what I've seen in our country is the states that are doing a good job embracing harm reduction and have a good, strong record in harm reduction, and where community members see like, okay, harm reduction works, they are the ones that end up having those supervised sites. Because people are already understand like, okay, this does work. Even though I had my preconceived notions, I can see how this helps. So I'm supportive of this facility, because there are a lot of community barriers to doing a facility like that. So those are, I would say, the states, New York and Rhode Island are two that come to mind. I would also say our tribal nations, recognizing tribal nations as kind of their own countries, right? A lot of our tribal nations are doing a good job, and not always IHS, but a lot of times they are. So I think the tribal nations do a lot of innovative things, and they're not as, you don't see them publishing or writing articles on the work they're doing as much as public health might or academics might. A lot of their work is done more silently and effectively, without a lot of PR, if that makes sense. So I think some of our most innovative harm reduction groups and powerful people are in the area of tribal health. And I'm going to say that for example, in Minnesota, that's definitely the case. So a lot of times people will look to like White Earth, because they seem to be the tribal nation that is really innovative and tries out new practices and tests them out and then shares what they learn with other tribal nations. Other questions?
See any?
I can stop the recording at this point if you would like.
Yes, that would be great. Thank you.